Okay, good afternoon, everybody. We're going to get started for the AASLD practice guideline session. My name is Jennifer Price. I'm a transplant hepatologist at UCSF, and I'll be co-moderating the session with Viral Ajmeril, who's a transplant hepatologist at UC San Diego. So we are going to start with Dr. Schwimmer, who will be presenting the AASLD practice statement on MASLD in children.
All right, thank you. And good afternoon. Thank you all for making it through a long day and showing up in the back of the convention center here. So I'd like to thank the organizers for the opportunity here to present the new AASLD practice statement on MASLD in children. And I'm doing this on behalf of not only myself, but also my co-chair, Dr. Stavros Anthakos. And in fact, the practice statement just went online this week, just a couple days ago here at Hepatology, and this QR code, in fact, will take you to the paper. So I'll pause there for a moment if you guys want to grab that. All right. So as background, in 2023, the AASLD clinical practice guidance addressed MASLD diagnosis and treatment in adults, and they recognized that there were enough pediatric specific differences in epidemiology, non-invasive screening, diagnostic, and treatment that it really was time for a dedicated pediatric guidance. And so they commissioned a committee of experts to provide evidence-based guidance on evaluating and managing MASLD in children. And this is our committee, like I said, Dr. Zanthakos and myself as co-chairs. And then we had 6 pediatric gastroenterologists and hepatologists listed here, along with a hepatopathologist, a pediatric endocrinologist, and a representative from the FDA. These are the disclosures that everybody had at the time of the writing of these documents. And so by the numbers, we spent 28 months reviewing the literature and putting these together. We have 255 references in the document, 6 tables, 8 figures, which led to 44 key points that supported 30 clinical practice statements, and also led to the production of 33 research priorities. Yeah, that may seem like a lot, but that's where we're at. The field has come a long way. There's a lot more we need to do, and these 33 areas are in these 7 subtopics. So the first clinical practice statement, and you will see that symbol up in the corner there when it's one of our specific statements, is on nomenclature. You may recognize this figure, although it is different than the one in the Ranella et al. Article, because we have adopted here for children. So in this first box, you'll notice right off the bat that there's a typographical error. I went back, because I just discovered that today. Looked at the figure we turned in, it did not have that. It had a V in the word liver. Don't know how that happened. This did go online just like this in its unproofed form, but trust me, in the proofing, we will address that. So MASLD, as it is in adults, is hepatic steatosis along with one or more cardiometabolic risk factors. How we measure overweight and obesity is different in children, but measures of impaired glucose tolerance, HDL, are similar. Blood pressure, again, different in children. Triglycerides, it depends on the age as whether it's similar or not. You see that second box has a more prominent position, the alternate etiologies of steatotic liver disease, because frankly, some of these are more common in children. Drug-induced is very important. Some of these miscellaneous categories overlap, as well as, particularly important in pediatrics, monogenic diseases and inborn errors of metabolism. Also important here with MET-ALD in the middle, you notice it says MASLD and alcohol consumption. We do not stipulate there's some amount of alcohol that's okay for children to drink and not have that considered to be a problem. So MET-ALD in children is MASLD and any alcohol consumption, cryptogenic steatotic liver disease and alcohol-related liver disease. Next practice statement on nomenclature has to do with recognizing zone 1 MASH as its own entity. So you see here across these panels the portal-based pattern of steatosis, inflammation, and fibrosis that we described 20 years ago. This is more often seen in children with MASLD and now should be known as Zone 1 MASH. Through the NASH CRN, it was being called borderline Zone 1 NASH, and frankly, the word borderline just confused people. So why is it important to diagnose and treat MASLD in childhood? It's because it's common, it's increasing, and there is genuine morbidity and mortality. So the prevalence of hepatic steatosis in children, as we showed on the left panel here in the SCALE study, is close to 10%. This was across San Diego County, and this is other versions that have been replicated around the globe. So anywhere from 5 to 14% of all children anywhere on the planet will have hepatic steatosis. It's about a quarter of children with obesity that have hepatic steatosis. The incidence of MASLD is rising. We looked at nearly 8 million patient lives across Southern California over a decade and saw that the annual incidence of MASLD increased 60% over that time frame. Fibrosis is also common in children with MASLD. So here you see the distribution from large studies we did in the NASH CRN, and you see that about 2/3 of children will have some amount of fibrosis. You will also see that that 1C type, that portal fibrosis, is common, and about a quarter of children will already have stage 2 or greater fibrosis. So it is a progressive disease. Portal fibrosis is much more common, and it can progress rapidly. We've seen even about 30% of children can advance quite a bit, even in 1 or 2 years. I'm very proud to be able to have one slide on this. This is a paper that just went online in its early advanced ahead of print version, the Longitudinal Investigation Evaluating Results of Steatosis, or the LIVERS study. Honestly, one of the most important studies I have done in my 25-year career to date. We looked at over 1,000 children who were diagnosed with MASLD during those years here at Rady Children's Hospital. The QR code there in blue will take you to that article. And we looked at mortality and morbidity. And we saw that the mortality rate was 3.98 per 1,000 person years, which is more than 40 times the standardized mortality ratio compared to children across the United States for age and sex matched. When you age and sex match for the state of California, it's actually more than 50-fold standardized mortality ratio. And we had high incidence of extrahepatic comorbidities such as type 2 diabetes, obstructive sleep apnea, hypertension, and dyslipidemia. Now, there are longstanding recommendations in children for screening. In 2007, the AAP recommended screening children with obesity 10 and older. In 2017, NASPGHAN said children who are 9 with obesity and potentially those who are overweight. In 2023, the AAP modified it to say, again, 10 and older, but now overweight or obesity using ALT. And so our recommendation is indeed to screen for MASLD in children. We've aligned with the AAPs to make it 10 and older. BMI 85th percentile or greater, that means overweight or obesity, or without that even if they have other cardiometabolic risk factors. And to consider screening for children who are less than 10 if they have an established diagnosis of one of these cardiometabolic risk factors or a strong family history of MASH, especially with cirrhosis. Now, ALT does have established utility in pediatric MASLD. You can see here we have normative data. We have screening data and sensitivities of 80 to 90% and specificities of 70 to 80% for ALT. And we even have shown that ALT is a good marker for response to treatment with ROCs of 0.8. And therefore, when screening, ALT is the screening test for MASLD in children. We do recommend using the validated cut points of 22 for females and 26 for males. And children who are incidentally found to have hepatic steatosis on imaging done for other reasons should have ALT evaluated. When to refer to pediatric GI and hepatology, if there are concerns for acute and or severe liver disease, or if there's persistence of elevated ALT. And then when that does happen, that should lead to a comprehensive assessment of that elevated ALT, a cardiometabolic risk factor assessment, an evaluation for steatosis, and consideration of a liver biopsy. So we'll look at those in a little bit more detail. First, in terms of identifying the cause, each one of these boxes that you see here has a detailed table in the document. I'm not going to go through those laundry lists of what to do in terms of testing for common conditions, what medications to look at, which questionnaires to use for alcohol and substance abuse. Those are all in the document, as well as the various inborn errors of metabolism to consider. Turning to the evaluation of steatosis, MRI-PDFF is the only validated non-invasive measure for steatosis in children. Here we see the 4 things that are most commonly used in some capacity: standard clinical or B-mode ultrasound, controlled attenuation parameter or CAP, CT scans, and MRI-PDFF. And you can see, looking at the things that may matter for steatosis, is it quantitative? Is it operator dependent? Do we have cross-sectional data? Do we have longitudinal data? And is it validated in children? In fact, the only one that meets all of these criteria is MRI-PDFF. So when it comes to imaging for hepatic steatosis in children, we have a stoplight approach here. MRI-PDFF is what's preferred. Why? Because it's validated and quantitative. Ultrasound, yellow, we do say it's an initial option when MRI-PDFF is not available or is impractical, or if there's concern for other anatomic abnormalities, it is a good test of anatomy. But there are genuine sensitivity and specificity issues. And red light with respect to CAP. CAP should not be used as a diagnostic tool for MASLD in children. It lacks pediatric validation sufficient for clinical decision making. Liver biopsy is an important diagnostic tool. Consider liver biopsy when there's uncertainty, especially if ALT is persistently elevated more than 2 times those biological upper limits of normal I mentioned. When there are clinical findings that raise concerns specifically for fibrosis and or MASH. And biopsy is also important when there are positive autoantibodies that suggest the possibility of autoimmune hepatitis, which certainly can coexist with MASLD. The presence of steatosis alone does not mean that a child may not have autoimmune hepatitis. Now, pathologists, it's important to collaborate with them closely. When they're interpreting these liver biopsies, they should have access to comprehensive clinical imaging and laboratory data. They shouldn't be reviewing these in isolation the way they may do in a clinical trial. And they should be using standardized, validated histology scoring systems to categorize the disease severity, but note that those are not the tools to make the diagnosis of MASH. The pathologist needs to do that directly. Research priorities for screening and diagnosis, these are extremely important. These must be validated in children's. Screening tests for steatosis, determination of really what is the optimal screening age. We are starting to see this disease at younger and younger and younger ages, how often to do it, and we really do need NITs that work for MASH and fibrosis in children. Comprehensive management, we have a sort of tier 1, tier 2 approach. So tier 1 for all children with MASLD. You see the child there at the center, gastroenterology and hepatology right there, working alongside primary care, considering things like lifestyle and behavior. And then tier 2, additional support is indicated for these various other things that we'll touch upon. With respect to nutrition for MASLD, it's important to start with a detailed evaluation of dietary habits, include registered dietitians when possible, provide tailored lifestyle counseling considering individual, family, cultural, and socioeconomic needs, recommending balanced, age-appropriate nutrition with adequate vegetables and fruits. And the thing that we have the most evidence for at this point is reducing added sugars. Daily physical activity, also evaluate the exercise habits. And this is now, we're talking about all children should engage in moderate to vigorous exercise daily. Activities can be free play or organized sports, depending on the age somewhat. And that should be age appropriate things that are done. And positive encouragement from parents and educators is vital in this. Now, this really is a big gap. So you look at research priorities. This actually led to us doing a systematic review. This QR code will take you to that. And the conclusion of that systematic review is that evidence supporting exercise intervention for the treatment of pediatric MASLD is in fact limited. Existing studies were constrained by their methodological approaches. Thus, there is a pressing need for high-quality future research. This will enable the development of precise, evidence-based exercise guidelines crucial for the effective clinical management of this condition. And so our statement is that future research is needed to identify the most effective exercises for children with MASLD, including optimal type, duration, and frequency of exercise. With respect to behavioral support for MASLD, it's important to screen children for depression or anxiety using validated questionnaires. Having anxiety and depression can affect adherence to lifestyle changes. Refer to pediatric mental health specialists if concerns are identified. Both family-based therapy and cognitive behavioral therapy are valid interventions, and motivational interviewing can also be used in the clinic for lifestyle interventions. Now, where do kids get their mental health care from? So it turns out that by far and away, the most common is school. You can see the other ones here. And as I was putting this talk together, this just came up in the past few days. The education department is slashing $1 billion in funding from school mental health. So if the majority of our kids are getting their mental health care from schools, 14% of children need mental health care in this country, and we're going to take that away, what are we supposed to do? So I'm here to make recommendations today. This is not an AASLD recommendation. This is me personally. But the great thing about us living from all over, not all of us are from the US perhaps, but many of us are, please talk to your representatives before it is too late and tell them that no, this money is desperately needed and should not be cut. Okay. There are no endorsed medications because no pharmacotherapies are currently recommended or approved as specific treatments for MASLD or MASH in children. Dietary supplements, including vitamins and herbs, should not be used to treat MASLD as none are proven effective and many carry risks of hepatotoxicity. With respect to clinical trials, now we're on research priorities. Clinical trials of interventions, whether they be for diet, exercise, medication, or supplements, in children with MASLD should use standardized inclusion criteria and validated endpoints, whether non-invasive, histological, or clinical. There's a paucity of validated endpoints in children, but changes in ALT, GGT, and MRI-PDFF have been shown to associate with changes in liver histology in randomized clinical trials. And all drugs that are approved for MASH in adults should be evaluated in children, including both in adolescents and school-age children. And these studies should include rigorous phenotyping of MASLD at baseline and follow-up to provide evidence of specific benefits for treating MASLD in children. With respect to weight loss medications, there are several medications that are now approved for treatment of obesity in children 12 and older. GLP-1 receptor agonists are the ones that have gotten the most attention and including just this week in the New England Journal, show real promise for adults with MASH. Benefits observed in adults, however, cannot be directly applied to children. Effectiveness of these medications in children for MASLD or MASH is untested. Treatment of emerging adults. So pediatric gastroenterologists, we will often follow children into young adulthood. And thus we have patients who are 18, 19, 20, etc. And those adults who are 18 and older, they can receive approved MASH treatments. Right now that means resmetirom as an option for those with MASH and moderate to advanced fibrosis. Of course, prescriptions must be aligned with the approved indications. With respect to metabolic and bariatric surgery, metabolic and bariatric surgery may benefit adolescents with severe obesity and MASH. Consider it more for those with significant fibrosis. Safety in children with MASH cirrhosis is unknown. A multidisciplinary team must be guiding the process here and thoroughly evaluating the risks and benefits. So comorbidity management, again, it's important to screen for those cardiometabolic conditions on this outer rim here. Monitor for diabetes, hypertension, dyslipidemia annually, as we've seen in our studies that these things do occur in high rates. We do have a detailed table in the practice statement to manage each of these conditions, what is done in gastroenterology, what should be referred. As we're following our patients, if there is a substantial rise in ALT, that really does require a new evaluation for either much worsening of disease or new causes. And we do note that statins can be considered for hypercholesterolemia and MASLD in children. So, children make up just 24% of our population, yet they're 100% of our future. So QR code here again on this final slide, if you didn't catch it initially, for the new clinical practice statement. Thank you for your attention. I look forward to your questions in the session later on.
Okay, thank you, Professor Schwimmer. We're going to discuss that paper after all three presentations as a reminder, and you can also submit questions online that we can incorporate in the discussion. Our next speaker is Dr. Andrew Aronson from the University of Chicago, and he'll be discussing the updated AASLD and IDSA practice guidelines on hepatitis C.
All right. Thank you so much, and thank you to the organizers for this invitation to talk to you about some exciting updates for hepatitis C from the AASLD and IDSA guidelines. All right, first of all, I don't have any financial disclosures. Okay, so the objectives over the next 15 or 20 minutes, I'll talk about some of the updates that we have from HCV guidance. Some of the highlights are going to be our new SVR4 guidance that will be available soon. Also talk about our test and treat algorithm using point-of-care HCV RNA testing, and introduce our new section about management of hepatitis C in the setting of hepatocellular carcinoma. So first, a little bit of background about our HCV guidance. This was a joint effort, and still is a joint effort, from the Infectious Disease Society of America as well as the AASLD, which was launched in 2014. And as you remember, this was a time when there was lots of new direct-acting antiviral agents, and this was really a place that we could make recommendations and keep up with the rapidly changing landscape of hepatitis C therapy. This was meant to be, and still is, a living document, meaning that as new things come up and new data becomes available, rather than having it just published, which it is every other year, but something that we can update more frequently. And I think that the focus of this document over the last decade or so has been to really keep it practical. So what would you do if a patient was sitting in front of you with hepatitis C? How are you going to treat it? And what is the best evidence to do that? And really be a nuts and bolts practical document that providers find useful and able to use on a daily basis. As I mentioned, we do have publications that switch back and forth between hepatology and clinical infectious disease. Our governance is somewhat unique from some of the practice guidance through the AASLD, in that we are combined, as I mentioned, at the AASLD as well as the IDSA. We have co-chairs for each of those, although we're a little heavily weighted towards AASLD here, I guess, but I promise there are some co-chairs from IDSA. We also have panel members who are members of our writing group, and other stakeholders like members from the CDC and other community partners who have an important voice in the recommendations that we make. All right, so jumping right into these updates, the first is SVR4. So many of you who may be treating hepatitis C on a daily basis know that it's sometimes very, very difficult to have patients come back 3 months after they've completed therapy in order to check for an SVR. And data has supported this. As high as 62% of folks who have gone through a complete treatment of their hepatitis C end up getting lost to follow-up at that 12-week mark. We also know that there's a very, very high concordance between SVR4 and SVR12. And this is important in patients that do not have cirrhosis and patients who have not been treated with DAAs in the past. So your non-cirrhotic, treatment-naive patients, SVR4 has a 99% concordance with SVR12. So based on the need and the data that's now available, if you look at the box below, the second box now allows for an SVR4. So an evaluation of SVR4 by quantitative or qualitative HCV RNA can be used as an alternative measure for people, again, important, without cirrhosis and who have never been treated with a DAA in the past. So the other direction that our HCV guidance is going is thinking about how can we support HCV elimination, and how can we support elimination goals even by 2030. So stay tuned in the next few months. Hopefully by the end of this summer, we'll have a new section. It's almost written. But I want to highlight what this is going to go over, talking about some of the important things that you'll see in the section that's going to support elimination. The first is looking at, actually, the second box is optimizing hepatitis C care delivery. So this is going to be strategies that dismantle health disparities, thinking about equity for marginalized populations. How can we really get hepatitis C care to these marginalized populations. Disseminating evidence to decentralize hepatitis C care. So what is the latest data and what is the evidence that's going to support use of telehealth, mobile health, treating and syringe exchange programs, really meeting patients where they are in order to offer them therapy. And then also kind of serve as a clearinghouse for any kind of new research on HCV elimination strategies. Now, of course, we won't make formal recommendations unless the evidence is there, but this would be a place where things like long-acting injectables or vaccine data can be housed of things that we know are going to be really important when we're thinking about eliminating Hep C. What I really want to talk about and kind of focus in on is what's going to be new that's already available is the support of a test and treat algorithm. And this is actually available now. And I'm going to get to that in just a slide. So what we've had now is the simplified HCV guidance. So if any of you have been treaters for the last decade or so, starting in 2014, 2013, it was really, really complicated and there was lots of if-thens and a lot of things you had to do. And this, which came out a few years ago, the simplified regimen, was a big step forward because now we could finally fit it onto one piece of paper. So this was our one-pager. PDF was available on our landing page of HCV guidance. And we were very proud of this at the time, although now it's somewhat a little bit outdated, but it's still great. And what it does is it takes you from the very, very beginning of how to evaluate the patient. It gives your pre-treatment assessment, so the labs that are needed, tests that are done, important historical questions to talk to your patients about. Goes over the therapy itself, so sofosbuvir, valpattosvir, pibrentasvir, glecaprevir. Talks about on-treatment monitoring and then what to do after you've completed treatment and how to look for an SVR. And this is available for non-cirrhotics and compensated cirrhotics who haven't been exposed to DAA therapy. So this is fantastic, but it does have a couple of limitations. So when you're thinking about in terms of vulnerable populations who may not be able to get back and forth to their provider's office, this requires, even in its most scaled down version, at least 2 trips to a provider. This is very difficult when you try to overlay this in a non-traditional setting like a mobile health unit or a community health service. This is not that easy to do. And probably most importantly, it doesn't incorporate point of care testing. So how can we add this to our current simplified regimen? And I think it's important to say that there will be a lot of settings where this is going to be still in use and it's still available on our website. But we wanted to add something else where you could also offer test and treat using point of care testing as well. So this is the Expert HCV RNA test. This gives a qualitative RNA result within an hour using a finger stick assay. So just a pinprick on the finger, you plug it into the machine, and within an hour, you're going to have an RNA result of positive or negative. So this is far better than what we've had in the past. All of our point of care tests have been, at least that have been available in the United States, have been antibody-based testing. And this was FDA approved last summer, and it's available now. So what I'd like to do is take you through our new algorithm, which enables people to use this in an appropriate clinical setting. This is available now on our landing page of the website. If you go to that first page, there's a PDF that has that's available. But I'd like to just spend a few minutes taking you through it. Starting at the top, that doesn't go up there. Starting at the top, point of care testing for HCV RNA, pregnancy, and HIV. And then if that is positive, then moving on to taking a good history from your patient. So asking if they've ever been exposed to DAAs in the past, if they're known to be hepatitis B positive, known hepatocellular carcinoma, or any sort of signs or symptoms consistent with decompensated liver disease. So do they have ascites, hepatic encephalopathy, jaundice, varices? If any of the answers to those questions is yes, this is probably not a patient that's going to be optimized to have this test and treat algorithm. We know that this is really going to be the minority, of patients that we're seeing. But if that is the case, of course, it's up to the provider, but usually this is going to be someone that will see a specialist to kind of think through some of these more complex issues. But as we know, in most cases, the answer is going to be no, and these are likely going to be pretty straightforward patients as far as their hepatitis C infection. And at that time, we recommend doing a medication reconciliation. drawing labs, an AST, an ALT, and a Hep B surface antigen, and importantly, giving medication at that visit. So the labs will need to be drawn, but the results don't need to be resulted at that time. So they just need to be drawn, kind of sent to the lab, but importantly, the medication can be given and actually started during that initial evaluation. Discussion of Hep B should take place with the patient, assessing that what you think your patient's risk for Hep B is, and also talking to them to say, if you do have Hep B and your test comes back positive, we're going to give you a call in a couple of days, and we're going to talk about how to manage that hepatitis B, whether it's through treatment or monitoring, according to our AASLD guidance of management of Hep B, hepatitis C co-infection. But as we know, in most cases, this is going to be negative. Follow-up for therapy, 4 weeks after completion of therapy. Again, you can use this as an alternative of 4 weeks to check for an SVR. And then if it's positive, this is someone that has not achieved an SVR through standard therapy and likely would require a specialist or someone with with some experience in HCV to talk about second-line therapies. But assuming they do have an SVR, this is when those labs become very important, because you now have your labs that you drew during that initial visit to calculate a FIB4, or you won't even need that if you do happen to have transient elastography or some other kind of mechanism of deciding whether they have advanced liver disease. And of course, if they've had a history of decompensation, then you know it there. If they don't have that, follow-up is going to be based on their risk of reinfection per our guidance. And if they do have cirrhosis, then these are folks that you would want to monitor for complications of cirrhosis and hepatocellular carcinoma per standard guidance. So I'm going to shift gears after our test and treat algorithm and talk a little bit about hepatitis C and hepatocellular carcinoma and management of both of these two diseases and our new updates in the guidance of HCV and HCC together. And this is a brand new section, and I think it was overdue because it was something that we get a lot of questions on, and I think is a really difficult conundrum when you're seeing a patient that has both of these of how to offer treatment. We know that hepatitis C is a leading cause of hepatocellular carcinoma, and guidance on hepatitis C virus management with people that have hepatocellular carcinoma so far really isn't available, at least in our guidance, and it's something that we get a lot of questions about and we all see pretty frequently in clinic. So there's a couple different pieces to this new guidance. The first is the treatment itself. So what kind of treatment should you use when you're treating a patient who is co-infected with hepatitis C and hepatocellular carcinoma? This one is pretty straightforward. So generally, the treatment regimens are unchanged, whether somebody has hepatocellular carcinoma or does not have hepatocellular carcinoma. There has been people looking at, and different data looking at whether treatment regimens need to change or whether you need to add ribavirin or other things, but there's insufficient evidence for us to support that. So our recommendation is that there is insufficient evidence to recommend modification in the duration of treatment, as well as addition of things like ribavirin if they have a prior history of hepatocellular carcinoma or a current history of hepatocellular carcinoma. So moving on to individuals who have a history of hepatocellular carcinoma, and what is the impact of DAA-based therapy on hepatocellular carcinoma recurrence or new occurrence of disease. And this one has been somewhat controversial over the years because there was initial studies that had, or some reports that showed high rates of HCC recurrence of people who had a history of HCC and were treated with DAA-based therapy, and some reports showing high recurrence rates of these people who have been treated with DAAs, and brought up some questions of whether DAAs somehow could be playing a role in putting patients more at risk. I think the summary is, and there's lots of large observational cohort studies that has essentially debunked this line of thinking and shown that actually multiple studies have shown lower risk of incident HCC in people that have SVRs after DAAs. And of course, we know that folks that have had DAA-based therapy have decreased risk of hepatic decompensation and all-cause mortality. So our recommendation is pretty clear for this, that prior history of hepatocellular carcinoma is not a contraindication to HCV treatment. So go ahead and treat away with these folks. Hepatitis C patients and people that actually have early stages of HCC, this one gets a little bit different. And I think the bottom line here is treat the cancer first. There has been achievement of adequate HCC treatment prior. Adequate treatment of HCC has shown to have actually a higher likelihood of SVR afterwards. And if you flip that around, there's actually some observational cohort studies that have shown that people who do not have their HCC treated actually have a lower rate of SVR with treatment. And active HCC at the time of DAA initiation has been associated with the higher odds ratio of DAA treatment failure. So this is where it changes a little bit as far as how we think about timing. And again, the recommendation here is to prioritize HCC treatment, hepatocellular carcinoma treatment, and DAA therapy may be deferred for 4 to 6 months after the initial treatment for early stage HCC in order to maximize the virologic response. So treat the HCC first and then treat the Hep C next. What about patients with advanced HCC? Now, we have a lot of talks at this meeting and at the liver meeting about great new therapies for advanced hepatocellular carcinoma. People are living much longer and much more treatment options every day. And multiple studies have shown improved survival in patients with advanced hepatocellular carcinoma who have had an SVR. SVR is actually improved in these patients with advanced HCC, has been shown to be associated with high improved liver function, better response to first-line therapy, and actually higher likelihood of receiving additional HCC treatment. So overall, treating their hepatitis C in the setting of advanced HCC is a good thing. So patients who are diagnosed with advanced HCC who have hepatitis C should still undergo treatment. I think the only caveat here is those who have very, very limited expected lifespan, and those who are not only even addressing palliative care, but maybe even hospice care, and it may not be appropriate in those settings. Question that comes up a lot is, what about drug-drug interactions? And these are actually, for the therapies available now for hepatocellular carcinoma, are pretty minimal. So you usually can have a fairly easy time treating the hepatitis C in the setting of advanced HCC. And then the last major point of this new guidance is talking about hepatitis C in patients with hepatocellular carcinoma in the liver transplant setting. There has been some reports of increased risk of hepatocellular carcinoma in folks with hepatitis C who have undergone liver transplant. Others have shown no association with HCC recurrence post-liver transplant. But our recommendation is that all liver transplant patients with hepatitis C should be treated and achieve an SVR to optimize their survival. So whether they have hepatocellular carcinoma or not, it's going to be a good idea to treat their hepatitis C no matter what. And our guidelines suggest this. The only thing that they're left a little bit to the provider and to the specific clinical context is the timing of treatment. So does it make more sense to treat that patient's hepatitis C prior to transplant or after transplant? And things like the patient's liver function, the likelihood of them achieving SVR, urgency for transplant on the waiting list, all these things are going to come into play, whether it makes more sense to do the treatment before or after, but certainly that we recommend that the treatment should happen at some point, no matter what. So that's what I have. I want to thank, again, the organizers for inviting me to give these exciting updates, and also, of course, our writing group members who do all the heavy lifting for all these recommendations. It's a pleasure to work with them. Thank you so much for your attention. I'm looking forward to taking some questions later.
Okay, thank you. And for our final talk, I'm pleased to introduce Dr. Mark Ghani from the NIH, who will be presenting the first ever look at the new hepatitis B guidelines. These are not hot off the presses yet. They're not actually at the press yet. So this is draft. They're currently up for public comment, and he'll be walking us through the recommendations that are public.
Great.
Thank you, Dr. Price, for that kind introduction. I'd also like to thank the organizers for the opportunity to present today. And I'll be presenting on behalf of my co-chair, Dr. Nora Turrell. Oops, to get them up here. Great, these are my disclosures. Oops. Okay, so as Dr. Price mentioned, this really is a sneak peek of the HPV guideline recommendations. The guideline is actually written, but it's still working its way through the approval process, and it's currently open for public comment. So I'm going to limit this talk to just talking about the recommendations, and I won't be covering any of the details of each of the specific questions that were addressed in this. And this is an evidence-based guideline that's different to some of the others, and this is the first one taking this approach from AASLD. This talk or presentation today really is an extension of this open public comment period, and I'd just like to let you know that it's only going to be open for another 3 days. So if you have any questions, please feel free to submit them, and we'll take them under consideration. The anticipated publication date of the full guideline will be sometime in early summer, if not sooner. So this is an overview of the guideline development process. We adhered to the National Academy of Medicine standards for trustworthy practice guidelines, and we used the grading of recommendation assessment, development, and evaluation, or GRADE approach, to formulate and categorize the strength of the recommendations. Multiple systematic reviews of the literature were conducted to support each of the recommendations. And the methodology team from the Mayo Clinic Evidence-Based Practice Center facilitated several brainstorming sessions in which the guideline panel developed structured questions following the population intervention, comparison outcomes, or PICO framework. And each member of the panel was asked to submit 5 to 6 questions. We received and reviewed a total of 75 questions, of which 6 were prioritized for development of PICO questions using the PICO framework. The panel also ranked the outcomes of interest to prioritize patient-important outcomes. So we used existing systematic reviews to address 2 of the PICO questions, and de novo systematic reviews were conducted for the other 4. Multiple databases, as shown here, were searched between February and December of last year, and the search strategy was designed and conducted by an experienced librarian with input from the methodology team at Mayo as well as the guidance panel. So the recommendations were developed in 3 steps. The first step was to determine the certainty of evidence. And this essentially is how confident were we of a study's results that they truly represented the effect of an intervention. And certainty could be high, moderate, low, or very low. And certainty could then be rated either down or up, depending on other mitigating factors such as bias, indirectness, indecisiveness, and publication bias, to name a few. In step 2, the panel applied the evidence to decision framework to balance the desirable and undesirable effects of different interventions or options, and considered contextual factors such as patient values, resource use, feasibility, acceptability, equity to come up with the recommendations. And recommendations could be strong or conditional based on the judgments of the ETD criteria. And I'll touch upon this on the next slide. And then the final step was a majority vote performed by the panel to determine the direction and strength of the recommendation. So a strong recommendation is made when guideline developers believe that all or almost all informed people would make the recommended choice either for or against an intervention. And a conditional recommendation is made when guideline developers believe most informed people would choose the recommended course of action, but a substantial number would not. So these are the 6 questions that we formulated, and they covered really 3 broad areas of practice of management of hepatitis B. The first involved prevention of both vertical and horizontal transmission. The second covered initiation of therapy in persons in the immune tolerant and indeterminate phases, and withdrawal of antiviral therapy. And the third question addressed screening in populations that weren't covered in prior guidelines. That is the group of people after S antigen loss and those co-infected with hepatitis C, hepatitis D, and or HIV. So over the next series of slides, I'm going to walk you through, in turn, each of these PICO questions, provide a rationale for why we came up with the question, address the knowledge gap that this question addresses, and then finally tell you what the recommendation is. So here's the first question. This deals with management of vertical transmission and what is the optimal antiviral strategy for S-positive pregnant individuals with HBV DNA levels above 200,000 IU to prevent mother-to-child transmission. So the population I just defined for you, the intervention was antiviral therapy with either tenofovir or tenofovir alafenamide, and the comparator was tenofovir versus no antiviral therapy or tenofovir compared directly to tenofovir alafenamide. And the outcomes that we looked at were mother-to-child transmission, provided the infants had received standard immunoprophylaxis, and antiviral safety. So we know that vertical transmission is an important cause of or contributor to the maintenance of chronic infection. And that's despite the availability of immunoprophylaxis with hepatitis B immune globulin and birth dose vaccination. And data shows that immunoprophylaxis fails in 8 to 10% of infants born to mothers with viral levels more than 10 to the 5. However, if prophylactic antiviral therapy is initiated at gestational week 28 and continued through delivery, among persons with high viremia, it effectively reduces the rate of mother-to-child transmission when combined with immunoprophylaxis, reducing that rate to almost zero. So the knowledge gap that we covered with this question is tenofovir alafenamide safe and effective in preventing mother-to-child transmission? And this wasn't covered in the 2018 guideline. So here's the recommendation. For pregnant persons with HBV levels greater than 200,000 IU, at any time point during pregnancy, regardless of e antigen status, AASLD recommends initiating tenofovir disoproxil fumarate or tenofovir alafenamide at gestational week 28 to prevent mother-to-child transmission. Tenofovir disoproxil fumarate has a more extensive safety record in pregnancy than tenofovir alafenamide, and the strength of this recommendation was strong, and the certainty of evidence was moderate. So PICO question 2 covered the issue of horizontal transmission, and should antiviral therapy be provided to persons who are surface antigen positive and viremic but do not meet disease-specific treatment indications to reduce transmission in high-risk scenarios. So for example, a physician performing surgical procedures. So the population, again, S antigen positive viremic patients in higher settings to transmit to surface antigen negative persons. And the intervention was use of antiviral therapy, and the comparator was no use of antiviral therapy. And the outcomes we looked at were HBV infection in exposed, uninfected surface antigen individuals. That is, surface antigen negative persons who then test S antigen positive, and then safety of antivirals. So the mainstays for prevention of horizontal transmission are still vaccination, universal precautions, harm reduction, and barrier methods. But it is biologically plausible that lowering the viral level with antiviral therapy may reduce this rate of horizontal transmission. So the knowledge gap is, would antiviral therapy be effective in preventing horizontal transmission from a viremic surface antigen positive person without a treatment indication, but in a high-risk scenario for transmission to an S-negative person? And this is the recommendation. For persons who are surface antigen positive with viremia, not meeting disease-specific indications and in high-risk scenarios for transmission to others, AASLD suggests a shared decision-making approach regarding antiviral therapy. The strength of this recommendation was conditional and the certainty of evidence very low. So PICO question 3 considered a very controversial issue, and this is the initiation of antiviral therapy in persons in the immune-tolerant phase to prevent development of hepatocellular carcinoma. So that's the population considered, and the intervention is antiviral therapy, and the comparator was monitoring or no therapy, and the outcome measured was hepatocellular carcinoma. So this is a controversial issue because the outcome data in this population is highly variable, and this is likely somewhat related to the fact that there are many different definitions used in studies to define this particular group of patients. Part of what we wanted to do with this guideline was to come up with a recommendation on how to define this population, and we defined the immune-tolerant individuals as those who are e-antigen positive with very high viral loads, more than 10 million IU per mil, but with normal ALT levels and minimal fibrosis. Such individuals are considered at low risk for disease progression, but high viral levels may increase the risk of hepatocellular carcinoma and viral integration. So the specific knowledge gap that we're trying to address here is antiviral therapy effective as chemoprevention for HCC in immune-tolerant patients? And this is the recommendation for persons in the immune-tolerant phase as I've defined. The AASLD suggests antiviral therapy for those over age 40 years or with significant liver inflammation defined as grade 2 or higher, or significant fibrosis defined as F2 or higher, either on biopsy or non-invasive testing. Now, for persons under the age of 40 years who are interested in starting therapy earlier, the AASLD suggests shared decision-making with consideration of risk factors as well as the benefits and risks of treatment. And the strength of this recommendation was conditional and the quality of evidence very low. So PICO 4 addressed an equally thorny question, and this is the use of antiviral therapy in patients in the indeterminate phase of chronic hepatitis B. I'd like to highlight here that we only covered the e-antigen negative indeterminate population. We did not consider the e-antigen positive, okay? And the population I've just defined for you, the intervention was antiviral therapy, the alternative was monitoring without therapy, and the outcome was hepatocellular carcinoma. So we know from emerging data that approximately 40% of surface antigen positive persons cannot be classified into one of the classic phases of chronic hepatitis B, and such patients are termed to have either gray zone or indeterminate chronic hepatitis B. And studies suggest somewhere between 0.1 and 3% of persons in the indeterminate phase may be at risk for disease progression and development of hepatocellular carcinoma over a 5-year period. So the knowledge gap covered here is antiviral therapy effective at preventing development of HCC among E-negative persons in the indeterminate phase. Again, we did not cover the E-positive subgroup. And this is the recommendation. In adults with S-positive, E-negative chronic hepatitis B infection without cirrhosis who are in the indeterminate phase, AASLD suggests antiviral therapy using a shared decision-making approach by assessing risks, benefits to reevaluate that decision at each follow-up visit if treatment has not been initiated. And the strength of this recommendation was conditional and the certainty of evidence very low. So the final PICO question that addressed treatment actually dealt with the issue of withdrawing antiviral therapy from surface antigen positive individuals without cirrhosis who have been on long-term nucleoside analog therapy, who are e-antigen negative with undetectable DNA. And the question was whether to stop nucleoside analog therapy or to continue it. And the outcomes that we looked at were surface antigen loss, clinical relapse defined as DNA greater than 2,000, ALT twice the upper limit of normal, and resumption of antiviral therapy. And we know that increasingly stopping antiviral therapy is being considered an approach to induce functional cure, that is loss of surface antigen, and thereby reduce the long-term medication burden and cost. However, such a strategy is associated with risks, such as virological relapse, hepatitis flares, and rarely hepatic decompensation and death. So the knowledge gap was covered by this particular question. Does the benefit of stopping therapy, that is achievement of S loss, outweigh the risks, hepatitis flares, need for retreatment, and hepatic decompensation. And this is the recommendation here. In adults with E-negative chronic hepatitis B without cirrhosis and who are receiving maintenance nucleoside analog therapy, AASLD suggests not withdrawing nucleoside analog therapy until S antigen loss is achieved. And the strength of the recommendation was conditional and the certainty very low. And now the final PICO question addressed the issue of HCC surveillance in populations that were omitted from the prior guidance. And these are individuals who cleared surface antigen and those co-infected with hepatitis C, hepatitis D, and or HIV co-infection. And the intervention is hepatocellular surveillance with ultrasound and alpha-fetoprotein every 6 months, or no HCC surveillance, and the outcome measure was early HCC diagnosis. So we know that HCC stage at presentation is the strongest predictor of outcome, and there's results from one randomized controlled study and several cohort studies suggesting that surveillance reduces HCC mortality and is cost-effective at an HCC prevalence rate of more than 0.2% annually. So the knowledge gaps covered by this question: is surveillance beneficial in those with HCV, HDV, and or HIV co-infection, and is surveillance beneficial after S loss? So this is the recommendation for persons who cleared surface antigen. AASLD suggests continued HCC surveillance for those with cirrhosis, a family history of HCC, men who cleared surface antigen after age 40, and women who cleared after age 50. This is a conditional strength recommendation, and the certainty of evidence is very low. What about those with Delta? AASLD suggests HCC surveillance of adults independent of cirrhosis status, but the decision to undertake surveillance in children should be individualized due to the risk of HCC risk being unknown in this population. And this is a conditional recommendation, and the evidence very low. What about those with HIV co-infection? AASLD suggests HCC surveillance for all adult males or persons greater than 40 years of age. Also a conditional recommendation, and the certainty of evidence very low. And finally, for persons with HBV, HCV co-infection, AASLD recommends treatment for hepatitis C, as you just heard, and then suggests HCC surveillance as per criteria for those with HBV monoinfection. Also a conditional recommendation and very low certainty of evidence. So this is my final slide. What is the potential impact of these new HBV guidelines? Well, difficult to say until they're actually implemented, but we anticipate that it should lead to reduced rates of vertical and horizontal transmission, and we hope it will lead to expanded treatment. In crafting the guidelines, I think the panel was very careful and considerate of the evidence and tried to recommend therapy to take a more permissive than less restrictive approach to recommending therapy. And where evidence was lacking, there was a focus on shared decision-making, whereby the provider and the patient could discuss the benefits and downsides of starting treatment and at least offer the possibility of starting treatment. And then finally, to broaden the population who may benefit from screening with early HCC detection. So there are a lot of people I have to thank for this presentation. I would like to thank all my colleagues on the Hepatitis B Guidelines Writing Panel, as well as the Mayo Clinic Evidence-Based Practice Center, the Practice Guidelines Committee, and the resource support staff, our IDSA colleagues, and finally, but perhaps most importantly, our colleagues for who these guidelines were drafted and hopefully will improve their cure. So thank you so much for your attention, and happy to take questions in the Q&A session.
Okay, I'd like to thank our presenters for those 3 excellent presentations and open these 3 papers for discussion. Go ahead.
Thank you. This was great. I have a quick question on Hep C. It was great to hear the the point of care testing in treat, which was good, and SVR4, which is new. I may have missed it, but are genotype no longer required? No, we don't get it anymore. There are potential populations that you might modify your therapy, particularly genotype 3, where they have
Absolutely.
advanced disease.
Yes, absolutely. So for these test and treat algorithms, there is not a recommendation to check a genotype, but you make a really important point that if you have any suspicion that someone might be a genotype 3 and that's going to change what you're going to do, you may have to do it if you're taking care of a population that has a higher prevalence of genotype 3 patients. But I think one of the concepts that comes up is we wanted to make sure that this was going to be as simple as possible, and when you start adding on extra tests, it kind of then decreases the value of it. But that is a very valid point.
Okay, while we're waiting for additional questions, I just have a question for Professor Schwimmer on the pediatric guidance. Do you have any guidance on which patients may benefit from genetic testing for the monogenic drivers of disease in the guidance, or evidence to support who may be benefit most from that type of genetic testing or evaluation?
So we do address that issue in the document, and specifically the farther a given child is from the prototypical patient, the greater the probability that they may have a different cause. So the younger they are, particularly the children that we're seeing who are 2, 3, 4, 5, 6 years old, the children who we're seeing who don't have an elevated BMI, et cetera.
I have a question for Dr. Ghani. I have a lot of patients who are in the indeterminate phase, a lot of them. And for the past couple of years, I've been saying, we're going to have new guidelines out. We're going to have new guidelines out, and we'll talk about them when they come out. So I'm wondering if you could kind of walk us through some advice about the shared decision-making of how you're going to approach your patients with this.
Yeah, so the recommendations came from a systematic review that was actually conducted at the request of AASLD. It was done by the Hong Kong group, and in those recommendations, what they looked at was what was the incident rates of HCC in this particular population, and the overall incident rate was 0.3 per year, 0.3% per year. But it varied quite greatly based on e-antigen status. So persons who were e-antigen positive, the rate was 1.2%, I believe. And if you were e-negative, it was 0.126%. So what they did was they looked at risk factors that were associated with development of HCC in this particular population, that is the indeterminate population. Now, they didn't do it by e-status, so they grouped all the patients together. That's those who were e-positive as well as e-negative. And they identified certain risk factors. So that was age, more than 40 years old, male sex, e-antigen status, and a platelet count below 180,000, which actually is normal, but the lower level of normal. But what the authors of the systematic review came up with, they said that there was considerable heterogeneity among the studies, perhaps due to the different definitions used to define the indeterminate population, as well as inclusion of both e-antigen positive and e-antigen negative patients. And although that systematic review showed that antiviral therapy did reduce the incidence of hepatocellular carcinoma, because of the considerable heterogeneity, they could not come out and actually recommend antiviral therapy as a blanket recommendation. Rather, what they recommended was to focus on the high-risk groups. So those are the people that I previously outlined, those older than 40, those who are male, platelet count less than 180,000, and e-antigen positive. So that's the group that you want to focus on treating right now. For now, I think the remainder of the patients need to be monitored. And as the recommendation said, at each visit, the patient should be reassessed for the need for therapy, because hepatitis B is such a dynamic disease that a patient who isn't a treatment candidate right now could be a treatment candidate 6 months later.
I have a question for Dr. Aronson. In terms of the liver stiffness measurement threshold that one would utilize to identify patients who will continue to need HCC surveillance, could you just comment on that and then the data underlying it, if it's an association with cirrhosis or a direct association with HCC risk in the future?
Yeah, so our guidance actually coincides with the portal hypertension guidelines and screening of HCC with cirrhosis for that. So I believe it's 13 and a half. I'd have to look at the number. I think that's what it is, but you'll have to check me on that. So those patients through the algorithm that are identified to have cirrhosis, either by FIB4 or transient elastography, should just go down the same pathway. Yeah.
Okay, don't be shy. Come up and ask questions if you have any. In the meantime, I have another question for Dr. Ghani about the, I think it was the PICO 5, the HCC surveillance, maybe PICO 6. So for the people, so you highlighted nicely what to do with people who were surface antigen positive and then lost S antigen. What if you don't know when they lost the S antigen? You know, what do you do then?
Right. Well, that only affects really, the recommendation about age. But if they have any other risk factors that predisposes them to HCC development, in other words, strong family history of cancer, obesity, alcohol use, any of these risk factors, I think I would recommend that these patients receive screening. As we know that the rate of S antigen loss is fairly low, so most people don't lose it till they're in an advanced age. Mm-hmm. So it's very unlikely that patients lose it early, particularly those who acquired it through vertical transmission. So I would err on the side of caution and continue to recommend surveillance for such patients.
I have another question for Dr. Schwimmer. So clearly there's a need to evaluate pharmacotherapy in this population, and you commented a little bit on some of the biomarkers that we can utilize. Can you comment on, there's abundant data about MRI-PDFF improvement in adults, and that was used in the design of many early phase trials, on that as a potential biomarker and the 30% reduction threshold in pediatrics?
So MRI-PDFF is a validated measure of hepatic steatosis in children. We don't have an established threshold for how much change in PDFF is required to equal a sufficient change in histology. In general, children with MASLD tend to have higher amounts of steatosis on average than many of the adult patients with MASLD. So the changes may not be the same. I think if you look at why has there been so much progress made in NITs in adult MASLD, it's because the number of clinical trials that have been done, the size of the clinical trials that have been done, the richness and thoroughness of those trials that have a biopsy before treatment, have a biopsy after treatment, and have the NITs paired at the same time as those biopsies, if they're imaging studies, or at least collected if they're plasma things that can be measured, thereafter. Without those wouldn't exist. And frankly, the field is trying to say, hey, we've already done this. Why do we have to do it again? And the reality is we have to do it again, for the reasons that I was trying to point out today, that there are millions of children who have MASLD. Some of them have it severely. Some of them are dying at very young ages. And so what can we use in clinical trials, the question that you actually asked. Mm-hmm. I think it depends on what is the phase of the study and what is the mechanism of the treatment. And so if a treatment is designed specifically to address steatosis, then measuring MRI-PDFF as an outcome makes a lot of sense. If the intent of therapy is to address the steatohepatitis component or the fibrosis component, then using PDFF as an extrapolate for those is problematic.
I have another question for you. So the study that you presented, the longitudinal study, the liver cohort, was pretty striking. And I don't know how many deaths there were in that 8.5-year follow-up, but what were the primary causes of death in these children?
So that's actually a very important question. The largest cause of death, it was slightly less than half, was liver-related deaths. And so I think this is one thing that's different about children and adults, is the competing risks for mortality are going to differ. And so I look at it as, because the teenager / young adult is at a much lower risk for cardiovascular death, for example, than the competition of the liver-related death has a chance to outcome. B, we know that there are some children who are rapidly progressive, and why that is, I think we still have a long way to go to understand that, but there clearly is a subset where that's the case. After the liver-related deaths, there were some cardiovascular deaths, but they're not the prototypical myocardial infarction. They're more of the heart failure-related deaths that we sometimes see, probably in association with obstructive sleep apnea, left ventricular hypertrophy, arrhythmias, maybe diastolic dysfunction, etc.
So could I ask a follow-up question on that? Because it's very sort of interesting that you're saying, as opposed to the adults, where most of the deaths in patients with MASLD are cardiovascular, you're saying in kids it was more liver-related? Did I interpret that correctly?
Yes, with the caveat that liver-related deaths were the leading cause of death. They were slightly less than half. So whether you talk about most common versus majority, I don't want to get tripped up on the semantics, but yes, liver-related death played a larger role in pediatrics.
So I guess my follow-up question is why? Does it have to do with this particular pathophysiology in kids, where you see this more portal presentation, or why is the disease more aggressive in the liver in kids? I mean, obviously they're much less risk for cardiovascular disease,
So
right, as they're younger, but why is the liver disease so accelerated?
Right. It's an important question, and I would answer it in a few different ways. Number one, I would proffer that the liver disease is more accelerated in all children. Why are they presenting as children? Why do they have this disease at 8, 9, 10, 12 years old? And we as a field haven't thought of pediatric disease as being a more aggressive disease, but the fact that it's presented 30 years earlier, I think, in and of itself is evidence that that's the case. And then there's a subset that have more advanced disease. So as I showed in the slides, it's about a quarter who already have stage 2 or greater fibrosis. Now, it's not a quarter, honestly, of all children with hepatic steatosis or NAFLD or MASLD, whatever you want to call it, because those aren't going to be the exact same answer, because it's really a quarter of the kids who come to clinical attention. And so, those are different numerator denominators. But, you then look at, okay, that's with stage 2 or greater. It's about 10 to 15% that have advanced fibrosis, stage 3 or 4. Now, most of those are really stage 3. The percentage that present with cirrhosis is small, but it's still 1 to 2%. And so we don't know why that is. That's an incredibly important thing that needs to be asked. But I think it's in the setting of all kids are progressing more quickly because they develop the disease. Some of them are super progressing. And then the last thing I would say on it is, and every pediatric gastroenterologist in the room will know this well, the burden of disease, and I don't mean just liver disease, I mean across the spectrum, the things that these kids are dealing with is often unbelievably high. We see, and I know, seeing 5-6 conditions, co-occurring in a patient is nothing unusual for all of you adult hepatologists. But for all of you that know children that are parents, imagine that your 10 or 12-year-old has 6 different health conditions, and maybe there are people in the audience where that is the case. They're facing a lot, and we really don't know how do all of these things interact with one another. Presumably they do. And then you factor in that, it's why I specifically called attention to the mental health crisis, because there are a lot of children who are facing very serious mental health problems. A number of them do need and receive one or sometimes multiple medications. Some of those medications probably are negative contributors, to this problem. And so I think hopefully what the liver studies will do is push the field to have not just this conversation at a table like this, but lots of other people starting to ask these questions more broadly, because I think we have way more questions than answers right now. Thank you.
I think I have a quick question. It shouldn't take too long. I'm Sarah Kadri. I'm from Baylor in Houston. I have a question for Dr. Aronson. So if I understood correctly, someone who has a newly diagnosed HCC, the recommendation now is to wait, I think, 5 to 6 months before you treat their hepatitis C. And I just want to make sure I got it right, just because most of my HCC patients are really well compensated. They have low MELDs, and especially the ones that may not even be considering transplant. I will usually do it in parallel. Like, I'll talk to them about both of them, and I'll say they're different in a way, and we're just going to go on 2 different routes, but in parallel. So should I now wait?
So
I guess, how strong is the evidence to wait now?
Jenny wrote the section, so
Jenny.
But I will say that, I think the evidence that you're talking, this is, first of all, for early stage HCC.
Yeah, so
this is like your
HCC.
2 to 3 centimeter HCC, and and I think the other thing too is based on and I'm curious what you're going to say here, kind of based on the patient scenario, because all it's really showing is you have a reduced rate of SVR, right? So is, and that wasn't, and if I'm not mistaken, that wasn't a huge reduction of SVR rate. So,
right.
This is, I feel like we've talked a lot about shared decision making, but certainly I've seen patients too that are like, what are we waiting for?
Right.
And that's the conversation, right? Do you want to, if you're not in this giant hurry, if they're, bordering on being decompensated and you're worried, they're going to need a liver transplant if you wait around and not treat their hep C for another 6 months. Then I think you have a different conversation.
Because I think everything else about hepatitis C is, like you said, the one appointment treatment. So that's why it's like.
So this is a little different. I don't know.
Yeah.
Do you have a different take?
The evidence is, it's mostly the observational evidence, right, of the active the active HCC being associated with lower SVR. So there's a thought that if it is treatable and you could put somebody in remission, that you might optimize their chance of SVR once the HCC has been treated.
Okay.
The difference here is, I think we used to, do the taste or whatever, wait the month to see if there was a response, wait the 3 months again to see the response, to see if there was recurrence, if there was, treat again. And people were just going along that pathway and then never getting their hepatitis C treated.
Mhm.
So the goal is not to kind of wait until it's gone,
Yeah.
to treat, but to give the person who it will be gone the opportunity to treat their HCC before you treat the hepatitis C.
Because doing it in that order is likely to help them achieve SVR.
Potentially.
And I wonder, I don't think this has been studied.
That was my only question. Is just how strong is that
But
evidence?
if you have somebody that you don't think you're going to see them again and they're not going to get their Hep C treated
Yeah.
unless they get treated now, I think you want to treat their
Okay,
Hep C,
no, my
right?
people come back.
But if they're prioritizing their HCC already, and you have them, they're going to be getting their procedure, next month or in a couple weeks. So you have them do that, then come back, for their
Just
treatment
wait.
initiation.
Okay.
That's it. Yeah.
I think I mean, I don't think this has been studied, but there has to be some sort of, burden of cancer burden that is going to affect the SVR that you have, which I don't know if there's data for that. Is a lot of cancer going to affect an SVR more than,
Right.
something that you've had a microwave ablation of a 2-centimeter tumor and it's pretty much gone. So there's probably some wiggle room with that as well.
Okay.
Yeah.
Thank you.
Just to follow on that, do you sort of define early versus advanced stage in the guidance for the HCC?
Yeah. So
Yes.
the early is sort of, it can achieve remission.
Hi. My question is for Dr. Schwimmer. Sorry, my voice is a little hoarse. I'm Sarah. I'm a pediatric hepatologist at UCSF. How would you recommend incorporating MRIs in clinical practice in our liver clinic or in our weight management clinic? And would you recommend repeating them at a certain time and potentially doing MRIs with elastography as well to look at stiffness?
So the answer to how do we incorporate MRI, I think it really depends on where one is practicing, because there is not much uniformity in terms of is it available, and not all MRI is MRI PDFF, and it turns out that not all PDFF is actually the same thing. There are a few different ways to do it, and there are some nuances there. And there are some places where it gets covered quite readily. There are other places where people struggle to get coverage, and it's why, even though ultrasound is very imperfect, we as a group still said it can be used rather than just saying no, don't use it because it's not good enough. So then it depends on, well, what's it being used for? Is it being used for making the diagnosis of steatosis, or is it being used to assess the severity of that? And then you're asking about, what about elastography? So although there's a little variation within PDFF, there's a lot of variation within elastography. Even as good as it is, it still has more variability. And so is it being used to say this is how much fibrosis a person really has, or is it being used to search for who has more fibrosis? Very different question and answer. And then in terms of what about not just in the diagnostic phase, but in terms of following it over time, we didn't make a specific recommendation as a committee on that because we don't have the data for that. I think that following ALT, GGT, we do have data that those are useful things to follow. And then it becomes, are you asking the question, did somebody respond to a given therapy, or are you asking the question, did somebody progress? And so the timing of those is going to be different. So it's hard to be exact. I think it can be reduced down to make sure you know what question you're asking with the test, and then that will really guide which test at what time.
All right, we have an online question for Dr. Aronson.
Oh, wow. I didn't even know that was an option.
It is.
Yeah.
Okay.
Any pointed recommendations for monitoring for hepatitis B reactivation in patients with isolated Hep B core antibody positivity who are undergoing treatment for their hepatitis C?
So let me just make sure I'm understanding. So hepatitis B core antibody positive during their treatment for hepatitis C. So we're
But surface antigen negative.
Surface antigen negative. So the recommendation now is monitoring during treatment, and this would be somebody that you would monitor. You wouldn't start treatment. You would monitor their hepatitis B during treatment, and this would be somebody that you probably would not put. I don't know if this was the context of this was test and treat. Again, this would be someone that would not qualify for test and treat just because they're a little bit more complicated and would require more monitoring and would kind of be in a different bucket.
Yeah, and I was going to say the anti-core positive persons who are S negative have very low rates of reactivation, and they definitely don't require prophylaxis. Case is very different if you're S positive. That's where we see the reactivation most commonly. And there was that study from Taiwan that actually sort of gave an idea or quantitated it. It was quite high. And these patients probably should be placed on prophylaxis during HCV therapy.
So that's the other reason why also we just recommend a surface antigen as the only thing to check. So we likely will miss some surface antigen negative and core antibody positive people along the way, but likely doesn't have any. It's so small and their risk of reactivation is so low.
Yeah, so just to be clear, so the surface antigen positive people are the ones not
Yes.
eligible for the test and treat, but if they're negative, we might not even know if they're
Right. I mean, in our test and treat, we say, do you have a history of hepatitis B? So
Yeah, exactly.
that would probably disqualify you. But then again, this is, specialist consultation is not like, well, you got to go. I mean, this is just somebody who has a working understanding of what kind of monitoring and understanding that. And I think that's who you want to speak to prior to moving forward with that.
I know this is out of the purview of the hepatitis B guideline, but we do get from the Hep C guidance a lot of questions about, do you really need to check the hepatitis B surface antigen in that test and treat model? And so what would you say?
Sorry, the question was.
We get a lot of questions.
Was it even worth asking about a hepatitis B surface antigen?
Yes,
Checking,
I think so.
Yeah.
I agree with its inclusion.
Yeah. Hard to get away from it. The next, I think the thing that we're very excited about, and there has been some movement on, is a point of care hepatitis B test that you would be able to kind of know everything right up front, and then you would have that, because we do get into a little bit of a gray area when you're saying, well, you check and then you have to call the patient and then you're kind of assessing whether you think that they're going to follow up and whether you're going to get a hold of them. So there is a little bit of a conversation there, especially if you're taking care of someone that you feel might be high risk. So if we can get this information from the same point of care test that we can do everything else, then we're really streamlining things quite a bit.
And we could probably get the algorithm on one page.
Then we can get it on one page. It'll be very exciting for me.
Yeah. Well, if there are no further questions, then we'll close this session, and thank you all for your attendance and attention.